Ma'am, from Nilofer we have joined, ma'am.
Hmm?
From Nilofer we have joined, ma'am.
Okay. Good.
Okay. Director.
11 people are there, madam. We will post once again in all the groups now. फिर हमारे लोगों को भी ज्वाइन करने का
Teja, I think we can start. It's 2:30.
Okay, madam.
Yeah.
Good afternoon, everyone. This is the first of the monthly clinical meeting that we're getting conducted in this year. We have Dr. Nirmala Madam, who is the president of the NNF, gracing this occasion. And we have two cases this time for the discussion. One case is from the Apollo Cradle and Children Hospital at Kondapur. First case, that is neonatal cutaneous erythema with blisters. Second case is that a journey of phenotype to genotype, a rare case of congenital chylothorax from the Rainbow Hospitals, Banjara Hills. First case will be presented by Dr. Ghulam Rafiq, and the moderator will be Dr. Sugna. Dr. Rafiq, are you ready? Dr. Sugna? I'll just call her, madam, once.
Yeah. Good afternoon, everybody. I welcome you all to the first clinical meeting of NNF State Chapter for the year 2026. And I invite all the faculty and professors and HODs to share the link with your PGs and let them participate in the interaction so that it will be learning for everyone. And also invite the different hospitals and colleges to present their cases as well, even if it is a simple case with, diagnosis, but with a difficult presentation or diagnosis can be chipped in or presented. They have joined, Tejo?
I think they are there, madam.
Yeah.
They're just trying to open it and then they will present it.
Okay. Narsimha, make them host if they are ready with their slides.
They can access directly, ma'am. Already I given access to them.
Right.
It's Sugna. Can you? It's Sugna is there, madam. She's
Purna.
there. She.
Okay. If there is a delay, I think we can ask Dr. Sneha, who has joined in, to present their case. Tejo?
Yeah, I'm just checking, madam, once. Just calling her once again. And if it is too much delay, then we'll go with others.
We acknowledge the presence of Tilak Chandrapal, sir.
Okay. They're just opening it, madam. Just one second. Dr. Sneha, you are ready with your presentation?
Sir. Yes, sir, I'm ready, sir.
Vijayanand sir is joining?
Sir, I gave a call to Vijayanand sir. He said he will join in a minute, sir.
Sure. We'll just wait for a second.
Yes.
If these people are not able to clear their technical things, then we'll try to look at it. Thank you. So is there any?
So for the information.
Yeah, I think so, madam, Sneha, Vijayanand sir is also there.
Yeah, I'm there, sir. I've just joined.
Sure.
Yeah. I think meanwhile, we can start with the case which Dr. Sneha is presenting. Meanwhile, I request Suguna to coordinate with your presenter. Yeah.
Yes, Suguna.
Suguna, are you ready?
Yes, madam.
Otherwise, we'll go with the first case with the rainbow, and then you can present
Yeah,
the second.
yeah.
Sure.
Okay, sir. Okay.
Sure. Dr. Sneha, I think open your slides and then start presenting it.
Yes, sir.
Dr. Vijayanand, sir, you can moderate it.
Yeah, I'm there. I'm there.
Sure, sir. Sure, sir.
So are my slides visible, sir?
Yes, your slides are visible. It is in the slideshow mode. You can start.
So, good afternoon, everyone. Today we'll be discussing about a
Just
case.
1 second, Sneha. If possible, you can
Yes.
open your camera, switch on your camera so that
Yes, sir.
everyone
Yes,
will
sir.
be able to see you. Okay.
Yes, sir. Shall I go ahead, sir?
Please go ahead.
Yes. So we will discuss a case of a journey of a phenotype to genotype, a rare case of congenital chylothorax. I'll be going briefly through the summaries of the case. So can you call my slides and
Yeah,
moving?
Sneha, దాంట్లో presentation లో చేయమ్మా.
Yes,
Zoom
sir.
దాంట్లోనే చేసి వస్తుంది చూడు.
దాంట్లోనే చేస్తాను, sir. I can't move my slides.
Otherwise, stop sharing once again and then reshare.
Yes, sir. I'm not able to move my slides.
Just try once again now.
Yes. Screen visible.
Audio is not coming.
Slides are not moving. So I'm not going to go to the next slide.
Yeah, it's coming now. Yeah.
So on the demographic details of the baby, this was a baby of Gautami, who was a baby boy born at term gestation with appropriate for gestational age, with a birth weight of 2.84 kgs on 10th of 10/9/2025 at 6:39 p.m. to a primary mother who is 29 years old by spontaneous conception and non-consanguineous marriage. Antenatal history: the mother had a regular antenatal checkups outside and presented at 35 weeks of gestation to our hospital in view of as the outside scan was suggestive of unilateral pleural effusion. Here, mother was diagnosed with the gestational diabetes mellitus at 36 weeks of gestation and was started on medical nutritional therapy. Risk factors like antepartum hemorrhage, hypothyroidism, UTI, oligo or polyhydramnios, maternal fever, all were negative. On the investigations front, mother was screened for a first trimester combined screening, which showed a low risk for common aneuploidies. And the scans were as follows. So the anomaly scan done at 20 weeks was normal. The first fetal echo done at 24 weeks of gestation showed a normal variant, a non-specific finding of reversal of pulmonary artery aorta ratio with normal crossing over of the great vessels. The scan done at 34 weeks showed a mild pleural effusion for which the mother was referred to the Rainbow Hospital. So the scan done at 35 plus 2 weeks had a appropriate estimated fetal weight of 3 kgs with AFI of 21.9 and Dopplers being normal with mild right-sided pleural effusion with normal cardiac access. That is, there is no mediastinal shift. And the next scan, which was done later at 36 plus 2 weeks, showed a mild polyhydramnios with an AFI of 24.3 and normal Dopplers with marginal increase in the pleural effusion from 1.3 to 1.6 centimeter with a mild mediastinal shift with a cardiac axis of 52 degrees. At this point, the mother was counseled for a detailed genetic workup as well as the requirement of the postnatal care for the baby. So these were the antenatal scans. Here we can see the... Here we can see the pleural effusion and without any mediastinal shift. In the next scan, there is an increase in the pleural effusion with a slight mediastinal shift can be appreciated. So the mother had a continuous follow-up, and later the baby was delivered by emergency LSCS. Initially was planned for normal vaginal delivery. In view of non-progression of labor, was taken up for emergency LSCS. Baby cried immediately after birth with an UPGAR of 7, 9 and 10 at 1, 5 and 10 minutes respectively. Delayed cord clamping was done. The weight was 2.84 kgs. Baby had an RD with a score of 4/10, and cord gas done at that point was 7.34 of pH, PCO2 of 39.7 minus 3.6 of base excess, and bicarbonate of 20.2. So baby was started on delivery room CPAP and was shifted to NICU for further care. So on day 1 and 2, when the baby was shifted down, we have started on CPAP with a PEEP of 6. The gas done later showed a pH of 7.2, PCO2 of 63.2, PO2 of 29, bicarb of 19.1, and a base of minus 2.7. In view of right-sided pleural effusion, we have placed an ICD which drained about 100 ml of pleural fluid, which was sent for analysis. On the day 2 also, there was an increased drain volume from the ICD, which was 110 ml fluid, which is 38.7 ml per kg per day, which indicates a large pleural effusion. And ultrasound tests done showed a moderate anechoic right-sided pleural effusion with a volume of 35 cc. This also comes under the category of severe pleural effusion, with both domes of the diaphragm moving normally. On the cardiac front, the 2D echo was normal with a good biventricular function, and neurologically baby was active and energy was also normal. Feeding wise, we have started on a full feeds with EBM. On examination, there was no facial dysmorphism, but there was bilateral undescended testis in this baby. So the investigation sent on day 1 and 2 subsequently were CBP showed HB of 16, WBCs of 12,000 and platelets of 2.54 lakhs, and CRP was 5, calcium was 8.4. Serum electrolytes were in the normal range, as well as urea and creatinine. The pleural fluid analysis, the color of the fluid was slightly turbid with a pH of 8, and pleural protein was 3.6. Sugar was 80, and the total cell count was 11,200 with a lymphocytic predominant. At this point, we were in the dilemma whether this will turn into a chylothorax, and the triglycerides at that point was 15 milligrams per dl. Baby, we sent a blood culture and started on piptaz as an antibiotic. On day 3, as the respiratory distress settled, baby was changed from CPAP to low flow oxygen, and there was a change in the color of the fluid and the consistency of fluid from the clear to turbid to yellow-white, raising the suspicion of the chylothorax. The pleural fluid analysis sent at that point showed a elevated triglycerides of 1552 milligrams, and hence the baby was shifted from exclusive the EBM feeds to MCT based milk diet, that is monogen formula. In view of the bilateral undescended testis and a chylothorax, to rule out other anomalies, we have done an ultrasound abdomen with pelvis. The other organs were normal, but there was no visualization of the right testis, both in the inguinal region as well as the scrotal sac, whereas the left testis was present in the inguinal region. And the blood cultures were sterile, so the antibiotics were stopped after 48 hours. The bilirubin was 13.9, requiring phototherapy, started on single surface. Pleural fluid culture was showing no growth. By day of life 5, we were able to wean off oxygen for this baby, and baby was maintaining well on the room air. When the drain output was less than 2 ml per kg per day, we have clamped the ICD and removed it. And later the chest X-ray also showed clearance. Once by day of life 6, we were able to reach the full feeds with the MCT based diet, and pleural fluid just before the ICD drain removal showed triglycerides of 79 milligrams per dl on full monogen feeds. So there was a decreasing trend of triglycerides. Cardiac wise, to the entire stay, the baby was hemodynamically stable, as well as neurologically also the baby was stable. So the trend of triglycerides immediately after birth, before starting any feeds, it was 15 milligrams per dl. On full EBM feeds, it was 1552, whereas when switched on to the monogen feeds, it was 79. So the summary of the case was, by based on a respiratory and feeding front, as well as the pleural fluid analysis. On day 1 and 2, the baby was on CPAP, was on exclusive breastfeeding, with the increased total count of 11,000 with a lymphocytic predominance. By day 3, we were able to change to low flow oxygen, and when the triglycerides came elevated, we switched on to the MCT formula by day 4. And by day 5, we were able to maintain on room air and full feeds with MCT based diet. And day 7, baby was on room air with ICD removed and on full monogen feeds with triglycerides being 79. So what was the cause of this? So on the investigation front, we sent for a newborn screening. Initial newborn screening was also normal, whereas the extended
Just a
newborn
second,
screening
sir.
Yeah. So
Sir, you want to stop somewhere, sir?
yes, sir. You can have a discussion here. Yeah.
There are
any
some
thought?
questions also, some answers also. You can just look at it, sir. That's it.
So on which day of life feeding was started and whether color turned white before starting feed or after? Okay, Sneha, you can answer. First
Yes.
day or Sneha? Yeah.
Yeah, first day itself, on the day of
Yeah.
admission itself, day of life 1, we have started on the full
Yeah.
feeds. Then by day of life 3, we have noticed the color change. Initially, it was a clear fluid.
Yeah.
Then the milkiness of the fluid, it turned into
Within 36 hours, it is changed, sir.
change.
So, yeah. And we haven't given much milk also. Is that right, Sneha?
Yes, sir. Yes, sir.
Yeah. Congenital lymphangiectasia, of course, is one of the differential. Yeah. So, any thoughts about is there anything else we should be thinking? Because we did not know bilateral undescended testis. Now it is clear that is congenital chylothorax. So, any associations were there? So I wasn't sure. We were not sure. Then we searched. Any thoughts? Anybody would like to put in the chat box? Anybody would have seen in the past similar association? Anything coming, sir? I don't see anybody's writing there.
I'm just saying, just wait for a minute.
Yeah, I think
Any
we should
differential
use it.
diagnosis people want to give, or some senior neonatology and pediatricians are there. You can ask some questions also if at all. Any other thing in the approach side, any other points that we have to look at it.
Tejo, sir, what we observed is always seniors are more interactive and Tilak sir is always we all youngsters should be inspired for.
So one of the differential Anshul has kept is Noonan syndrome. Yes, that is one possibility.
Correct.
Okay. And then do you have
When there are few
from the Center
syndromes,
of Excellence, Nilofar people want to unmute and tell any points?
No. Okay. Sneha, shall we go ahead, sir?
Yeah. No problems. Yeah, sure. You can go ahead. Sure.
So
I think you can just tell whatever your yes, the workup will come later, but
yes, sir.
can you tell the differential diagnosis which you have considered at that time and then why you did that workup? Okay, that's
Yes,
it.
sir.
Or while you are telling the workup only, what you are ruling out also you can tell.
Yes, sir. The first thing is this was an antenatally detected pleural effusion, which later turned out into chylothorax. So this is a congenital chylothorax rather than a traumatic or the post-traumatic one. So in a congenital chylothorax, one, as they were discussing, it is lymphatic malformation or any thoracic defects can cause this. And it will mostly be a right-sided because of the thoracic duct positioning being right side. The other things are here syndromic. So it can be either the lymphatic malformation itself or the syndrome. Syndromes could be Down's, Turner's, Noonan's, Costello syndrome, Ehlers-Danlos syndrome. As this is a male baby, more in favor of Noonan's and the Down syndrome. And the aneuploidies. The first trimester screening showed a low risk for aneuploidies, so probably lesser chances of Down syndrome. And the faces and the soft markers for Down syndrome were also not there in this baby. There was no facial dysmorphism as such. It could be any of the syndromic presentation of the congenital chylothorax, and even in any torch infection can also cause this unilateral. They can present in this way. Was our thought processor at that time. So we have done a a newborn screening as well as a torch profile, which was non-reactive. Then, so at this time, our diagnosis, it was a term baby, which AGA, RD with CPAP, having a right-sided congenital chylothorax, and non-visualized right testis in the right inguinal canal as well as the scrotal sac. So it can be idiopathic, congenital, or syndromic, such as Downs, Noonan, and Turner, as this was a male child, more in favor of Noonan and Downs. So should I reveal it, sir? My next slide would be.
Vijay sir, any other comments that you would like to?
Yeah, no, I think Sneha explained very nicely. So the question is, you can have isolated congenital chylothorax also, but here the suspicion was the bilateral undescended testis which made. Then you do head-to-toe phenotypic evaluation, and there was no obvious dysmorphism. But bear in mind, the dysmorphism can evolve over the time, depending upon which syndrome you're talking about. But at that point, nothing was obvious. Then we look also evaluation of the internal organs. Again, nothing is obvious. Then we said, okay, we'll try to do this, and then we also searched the literature, and these were the syndromes which were supposed, because it's not just isolated that made us to think the genetic or chromosomal underlying condition. So the good thing is the chylothorax relaxed, family is happy, but is that enough? So is the family can be happy forever? Of course can be, but again, we told the family that more to come, more to be evaluated, and we did send the genetic analysis, I think, which Sneha will talk about. Yeah.
Sure.
So the whole exome sequencing that we have sent showed a autosomal dominant variation of the Noonan syndrome with a mutation at PTPN11 and exon 3. So there was also a autosomal dominant variant of the neurofibromatosis type 1. So the congenital chylothorax could be a presentation of the Noonan syndrome itself.
And our geneticist, Dr. Sarah, is there. Sarah, are you there?
Sir,
Yeah. Are you
sir,
there?
good afternoon, sir. Am I audible?
Yes, you are.
Yes, sir.
Would you like to comment?
Yes, sir. So this is a whole exome sequencing, which shows the PTPN11 having the tyrosine to cysteine change, heterozygous variant. And if you look at the classification, it is pathogenic. So which means that it is well-documented variant, which is a well-studied variant. So we can confirm that it is Noonan's with this report. And the second variant, the NF1 variant also they have mentioned, but the classification for this is uncertain significance. So uncertain significance based upon the clinical correlation and familial segregation, we can rule out NF1 over here because it's not matching. And the common variant of PTPN11. So there are around 13 genes which cause Noonan syndrome. And the commonest 50% of Noonan syndrome have the PTPN11 mutations variant. So based upon this report, it's conclusive that it is Noonan syndrome. Around 20% of Noonan syndrome have lymphatic abnormalities, and 4% among those have chylothorax. So it's a rare presentation. And because Noonan syndrome is an autosomal dominant, in autosomal dominant conditions, variable expression and incomplete penetrance are known phenomena, which explains the lack of dysmorphism in the child and absence of other features, and also evolving phenotype, which Sir mentioned.
And this child is yeah. So would you tell the current status, Sneha? Yeah, this baby is coming follow up. You are on mute. And I also seen Dr. Sarah as well. And family does know that this is a lifetime condition and needs to be under regular follow up. Yeah. Okay, Sneha, go ahead.
So for the congenital chylothorax without any RD, we usually start with the MCT-based diet, MCT-based formula, that is monogen formula, and we continue it for 6 weeks. So we have done the same for this child also. And then we have switched slowly from the monogen feeds to the EBM feeds. At So at 3 months, I know that the baby was on 50% of monogen feeds with 50% of our
It's
EBM, and
completely
there was no
mother milk now.
recurrence.
Yeah.
And there was no recurrence of chylothorax, and the chest X-ray has been clear since then. We didn't have any recurrence problem.
And
So-
also under follow, they came to your outpatient as well. Is that right, Sarah?
Yes, sir. They had come for the
Yeah.
with the reports, and so at that particular time, although it was pathogenic, I noticed in the clinic that the father, who is an IT professional, had down slanting palpebral fissures, typical Noonan faces with a normal intelligence and normal stature. So we did a segregation in the parents, and as expected, the variant was seen in the father. However, it was difficult to counsel the family because suddenly giving a diagnosis in an adult that you have Noonan syndrome becomes quite challenging for the family to accept, as well as tell them that there is a 50% recurrence risk in the future pregnancies, and also counsel them about the need of doing the antenatal, prenatal testing in the future pregnancies by either CVS or amniocentesis. So this was spoken to them, sir.
And also, it's important to understand and recognize and realize the disturbance it can cause in the social dynamics. So we have to be very cautious about that. Yeah.
Yes, sir. Yes, sir.
And yeah. So Sneha, go ahead. Do you have any more slides?
No, sir. No, sir.
Okay.
That's the.
So maybe we want to hear from Dr. Sarah. So just you want to say a couple of points or minutes about the long-term prognosis and the other adult patients you have seen and your experience with the Noonans, Dr. Sarah.
Just another
Yes,
point.
sir.
Yeah, sir. Go ahead.
Yes, sir.
Just I think while she's telling, like any Down syndrome baby and other things, which we have the structured follow-up program for the Down syndrome, do we have for the Turners and Noonans, Sarah? Because these are all milder diseases at birth, and then
Yes,
we.
sir. The surveillance chart, right, sir? So, yes, sir. We do
Yes.
have a surveillance chart recommended. Actually, we refer to gene reviews for surveillance. And then, so we do follow those. And again, depending in Noonans, we have particularly genotype-phenotype correlation. So PTPN11 gene and KRAS gene mutation should be followed up for cancers. So skin as well as blood leukemias. So we put them on the surveillance. So these charts are available, sir, on gene reviews. And RIT1 mutation is associated with the chylothorax. But however, in this child, we found it in the common gene.
Dr. Sneha, was it a May? Sorry.
How do you counsel the
Mm.
parents once you have initially counseled regarding the need for the respiratory support and all after delivery? I mean, antenatally itself. But then once the genetic report, so how do you counsel and communicate with them? That yeah,
Sarah,
Dr.
you want to answer? Yeah.
Yeah.
Counsel regarding the long-term, ma'am? Is that
Yes,
you're asking
immediate,
about how?
short term, and long term.
Yes, yes. Okay.
So how do you do it in a phased-wise
Long-term,
manner?
okay.
You do it, or how? Because our
So
postgraduates are
initially,
also practitioners. Sir.
Yes, madam. So initially, when in the NICU setup, it is acute management. And then later on, when they come with the reports, we break it down to them slowly. Of course, we don't want to shock the family and this thing. So we tell what is the report, what is PTPN11, what is Noonan syndrome. And also that there are normal individuals, asymptomatic individuals, although they have the Noonan syndrome gene variant. So this child can grow up to be completely asymptomatic, just like the father, or can have different systemic involvements like developmental delay, short stature, cardiac issues, and that we will need to do surveillance for each of this. And according to the gene reviews below 5 years of age, it's mentioned to do it every year to get the cardiac evaluation, and above 5 years of age, then do it every 5 years. So we give them the surveillance chart and tell them to be in touch with the developmental pediatrician. Here, of course, I mean, for the first few days with the neonatal to have little assessment with behavioral assessment. And Noonan syndrome in general have, compared to the other genetic syndromes, are quite good actually. They develop well, and not all of them have short stature. And for the short stature, endocrinology consultations with growth hormone evaluation and option of growth hormone injections can be given, except for PTPN11 and KRAS, wherein there is a chance that the child may develop cancer. So growth hormone can have side effects in those genes. So those should be communicated as well. So in general, it's not a very poor prognosis. We have seen completely asymptomatic Noonans as well. When we do the parental screening, we find that the parent is a carrier and has been asymptomatic. So we don't paint a very poor prognosis in the beginning itself, but offer a phased-wise surveillance to these children.
And most of the times, you see in your office practice, first thing they will ask whether it had come from the mother or the father. How do you counsel? No, this is the common
Yes,
thing which
madam.
you
This is
face.
common
Yeah.
question. Yes.
Yeah.
Yes, madam.
How do you answer that?
So we say that we will need to we will examine the parents, and of course by then we know whether it has come from mother or father of the time. In this case, it was from the father, and then tell them about autosomal dominant inheritance. We say that we will need to do segregation testing in both the parents, as well as we also need to make sure that we tell them that genetic conditions is not any person's fault per se, and so that there is no blame game involved. So this all has to be communicated during the genetic counseling. And we also said that the only reason we are testing the parents is so that we can put them on an appropriate service to prevent any complications, and also to be able to provide them the appropriate prenatal testing in the future pregnancy to prevent such recurrences. So this is the reason which is given to them, and so that there is no others. And we also see that there is no other psychological underlying issues going on based upon the information that we are giving them. So it's a little bit complex, but try and do it in the most suitable way.
Yeah, you should be very careful while counseling because
Yes, madam.
it involves the family and extended family as well. Yeah. And there are some questions,
Yes,
Dr.
madam.
Tejo, in
Absolutely.
the box. I mean, how do we explain non-recurrence of pleural effusion with expressed breast milk over time? And is there a chance for recurrence of chylothorax in the same baby later?
Dr. Vijayanan sir and Dr. Sara.
Yeah.
The question is that how do
Yeah.
can we predict whether there is any possibility of recurrence? That's a main thing.
Yes, sir. Sneha, do you want to answer? Do you want me to answer?
Yes, so it is given in the literature that once we start the MCT diet, and in case of a lymphatic obstructive cases, there can be extra channels forming, that is later on, so that this will cause the lymphatic drainage, and will if it is not recurring, it is mostly due to that, is what is
Correct.
that's what I
And we know that the MCT is directly absorbed to the portal circulation, bypasses the lacteal circulation, and meanwhile the extra or collaterals will form in case of congenital lymphangitis. In case of trauma post-operative, it get healed. So you are buying the time for that to develop. So typically, as Sneha said, it is 6 weeks, but it could be more than 6 weeks also. So, and we are lucky in our case because it is stopped with MCD, but if not, we have to go to actotide, if not total TPN, and then it can take longer. And we have seen post-op cases where it has taken more than just 5 to 7 days, 2 weeks, 3 weeks also. So yeah, that's the reasonable explanation, I would say. And also here the positive thing is we can also counsel the family, as the father himself is IT professional, as having a near normal life. So it's all this is not that bad compared to other genetic syndromes. So I would say try to see the
Yeah,
Sorry,
only
sorry.
thing as she told that some cancer risks and other things we need to
Correct.
keep an
Always
eye
there is
on those.
and also knowing early will also work towards the monitoring, and also you can have an endocrine review and considering getting the optimal height with the help of the growth hormones. Yeah. I stop it there, sir.
Completely agree, sir. Completely agree. I was just looking at one more query which was lingering in my mind is that suppose you have the child with a chylothorax, and then we have put them on the simultaneity.
Yeah.
So there is a possibility for some collaterals to develop.
Yeah.
At any point of time, can we go with a little normal diet for that, or I'm not sure. I have not followed these cases for a quite long, but
you are absolutely right. There are people who have tried skimmed EBM.
yes,
So
yes.
they have taken up the fat and given, but again, nutrition is equally important. So that's one thing. But again, if you're trying, by the way, monogen feeds, complete MCT is not available in India. We have a dietitian who bought from the some source from UK or US, and then there is meta-nutrition is also available, but it doesn't work as good as monogen in our own experience. And there is all MCT has got lower, sir, relatively higher to the compared formula. I think it is around 15-20%, not more than that, if I remembered correctly. Whereas monogen, the trade name MCT complete is 85%. So higher the MCT, the better the improvement. And yeah, but you are right. You are right. People have tried that. And even when you switch over also is a transition. So you don't suddenly change, you will gradually change. Yeah. I think Lingareddy sir, we answered your questions are already. How will you treat chylothorax?
IVIG octreotide.
Yeah.
Mm.
Yeah,
Okay.
and of course, your brain, if it is compromised respiratory status, yeah. Incidence, Sarah can say. Actutide, yes, I don't know IVIG. IVIG, sir, Tejo, sir?
IVIG, if there is a for a
Only
longer time, there is a
immunoglobulin.
chylothorax and
Right.
immunoglobulin will be low, then we should give an IVIG.
So while the chylothorax is there, sometimes there can be associated immunodeficiencies because of the loss of these immunoglobulins through the.
Well,
So
yeah.
there is a literature that in some of these kids we need to supplement
Yeah.
it. Okay.
If you
So that's
do,
other
if
thing.
you have a loss, you treat, but you don't treat chylothorax with IVIG.
Yeah.
Yeah. It's other
So
way
it's a
around.
supplement.
Okay.
It's
Yeah.
a supplement. That's
Like
what.
nephrotic child. Yeah.
It's a supplement.
Okay.
That's all I wanted to answer, and then we'll move on to the next case.
Excellent. So, Sarah, do you want to say the incidents? I don't know. I don't remember.
So, the of Noonan syndrome, sir,
Yeah.
it is
Yes.
around 1 in 2,500 live births.
Okay. So
Not very bad.
not uncommon. Not
This one?
uncommon. Not uncommon. It not rare either.
Yes.
Yeah. Okay.
That
Okay, sir.
any other final comments, madam, and then we'll move on to next.
But Tejo, have anyone of us seen these cases so frequently? As Madam says, 1 in 2,500. So each one of us must have seen more than these cases.
I have seen, sir, at least 3 cases we have seen.
Sir, can I add a point over here?
Yeah. We have seen, sir. We have seen, sir.
The IVIG in chylothorax is not for immunodeficiencies. In fact, the chances of infections in chylothorax are more. To prevent that, they advise IVIG. That's what the literature says.
Yeah. So similarly,
Same meaning only I tried to tell, sir. It's not any other things. Yeah. Sure.
Yeah. So that's what we said, sir. It's not to, agree.
Yeah, I think it's a good case and well managed and went up to the final diagnosis with the counseling of follow-up. I think we'll move on to the next case.
Yeah, Dr. Sneha, can you stop sharing?
Yes, sir.
Yeah, Dr. Signa's team, can you start sharing the screen?
Yes, sir. No, share this. No. Yeah. This is.
Thank you, Sneha.
Yes, sir.
Yeah, you can make it to full slideshow mode and then start off. Sure.
Good afternoon, sir. Actually, this is a case of neonate with erythema, almost looking like bright with blisters.
Good afternoon, sir. I'm presenting a case for her of a 15-day-old late preterm, 34 plus 4 weeks, male unit with birth weight of 1.8 kg, born to a primary mother, came to OPD with complaint of skin peeling since 1 day and inconsolable cry. The infant was exclusively breastfed. There was no history of significant antenatal or perinatal complications. And there was no history of NICU admission at birth. This is the pic depicting the case quarter I am presenting now.
You don't want people to think about the
This
differential?
is the case. So baby presented on 15th day of life with late preterm low growth weight baby. So these are the skin lesions. So initial lesions are started at the periumbilical area. Initially started with blisters, then rapidly within 12 hours, rapid spread of the lesion and yeah. So
Sukna, shall we ask the others to give the differential? Tejo sir?
Yeah, I think better, sir. Better.
Yeah.
Can you people start typing? Others. One is somebody has Epides staphylococcal scarlet skin. So obviously, as expected, Tilak sir is first top 3. Okay.
Agree.
Okay, sure.
Okay.
Ichthyosis. Which type of ichthyosis you want to say? Something.
Okay.
I think we can start off with that. Okay, sure.
Only SSS or anything else? Another skin similarly?
Congenital bullous.
Okay.
10 is a little difficult in the newborn, but yeah, you can look at it. Any other people? Okay. Okay, epidermolysis bullosa. Sir. Okay.
Agreed. Agreed, sir.
Okay. Sure.
Okay.
Toxic epidermolysis.
Toxic epidermolysis necrolysis and pemphigus vulgaris.
So differential diagnosis, it is a case of staphylococcal scalded syndrome. So typical presentation started with blisters around the periumbilical area and actually it is typical textbook description until like involvement of the face first and periumbilical area and the blisters rapidly progress to peeling and rupture of the blisters and then no oral mucosa involvement. And compared to like other like congenital bullous epidermolysis bullosa, they present at the time of birth. They present staphylococcal scalded syndrome. They present later, like after few days of life. And
the skin blisters began abruptly around the periumbilical area and perioral region and rapidly progressed to involve the face, trunk, abdomen, extremities, and flexural areas. Baby had excessive crying, irritability, poor feeding, and vomiting. And there was no documented fever at onset. Subsequently, baby had facial erythema followed by generalized denuded areas of lower abdomen and generalized cutaneous tenderness. There was significant perioral crusting, radial fissuring around the mouth without mucosal involvement. There was widespread desquamation within hours with painful, shiny, denuded patches. The desquamation was even more with gentle stroking of intact skin, suggestive of Nikolsky sign positive. And on examination, the neonate was irritable with excessive crying and vital parameters were stable with a temperature ranging between 36.3 to 36.5 degrees centigrade. And heart rate was around 150 beats per minute and oxygen saturation was 97% on room air. And weight at admission was approximately 2 kgs. Dermatological examination revealed diffuse erythema with extensive superficial sheet formation and large denuded raw areas involving the face, trunk, abdominal extremities. Surgical assessment was unremarkable. Systemic examination including cardiovascular, respiratory, abdominal was normal. Baseline investigation including CBC, C-reactive protein, blood glucose levels, renal function tests, and blood cultures were performed. Blood cultures remained sterile. Renal function and glucose level were monitored serially. Culture from skin lesions were non-contributory and the diagnosis was made clinically. Based on the acute onset, rapid progression, and clinical skin findings, positive Nikolsky sign, absence of mucosal involvement, a diagnosis of staphylococcal scarlet skin syndrome was made. And the different toxic epidermal in which mucosal involvement is present.
Drug history.
And there will be a drug history. And bullous impetigo, in which large slashes fluid-filled blisters, in which organism present in the lesion, and epidermolysis bullosa, which is congenital, recurrent, and present at birth. Congenital herpes, in which vesicles and systemic illness is present, whereas in syphilis, vesicobullous rashes are present. This is the baby. This pic is the baby during the discharge.
No recurrence of
and no recurrence of the lesions.
Excellent. What antibiotics did you use?
We started initially clindamycin, sir, but actually baby had secondary sepsis, vancomycin and meropenem also we given. And the secondary sepsis, baby had fluid electrolyte imbalance. Baby had absolute neutropenia, so we have to step up the antibiotic. But cultures are negative. We gave the antibiotic for 7 days. And actually pain management also very important in this case. Baby is very irritable. Almost if you touch the baby, heart rate is going 200 to 220 like that. Pain management and fluid electrolyte balance, and one more thing, skin care. So liquid paraffin, actually we have to apply only liquid paraffin without any keratolytic agents. So that is also important, and no role of local antibiotics or antiseptic these things.
Correct. So the Clinda is the right choice to start with.
Yeah,
Because,
cutaneous absorption
toxin
will
mediator,
be good.
And also it decreases the toxin production from
Correct,
the
sir.
organism.
Correct, sir. Teja, sir?
Case, but any other learning lessons that you want to tell?
One more important thing, actually, there is a isolation is a very important if you are managing in NICU, and hand hygiene, maintenance of hygiene for the preterm. This is a low birth weight baby, so they have actually the pathogenesis also. They will say that it is immunological and renal immaturity, and they have low levels of anti-exfoliative toxin antibodies. That's why hand hygiene is very important in this type of.
Yeah, that's important. Again, epidemic control and other things in the unit. That's Did we screen for the people when they, because
family members also. If recurrence of infection is there, we have to screen for the family members for the any focus of infection.
Because that colonization status of the family, and if required, we have to treat nasal swabs and other things. Because was it a MRSA or was it a simple? We are not able to culture it. Culture was negative.
Culture was negative, but actually, initial blood culture is negative, but skin swab sometimes. If the blisters swab also, it is not showing any organism.
Yeah, usually we don't expect in the swab to go
That's
the
actually
culture because it's a toxin mediated one.
toxin
But
related.
Aggravated change.
so I was just thinking that if there is any gram positive in
Okay.
blood culture, that can give you a little idea that whether it's MRSA or normal MSSA. If it is MRSA, definitely we need to look for the carrier status of all the contacts who are there, and then we need to treat them also. That's another job we need to do it as a epidemiology person or a public health perspective that we need to look at it. Okay. Yeah. Okay. Any other comments from the seniors or anybody? And then I will hand over to. Tilak sir, you want to say something?
Nothing else, sir. Well presented, both of you.
Only answers, sir. No questions, sir. Okay.
Thank you, sir, for active participation.
Any other people? For Dr. Poshan, we have Dr. Lingareddy sir. Rajshekar sir is there.
Raja, sir, Surendranath sir also there.
Surendranath sir is also there. Alok Bandari sir was there for some
Alok sir is there.
Any other comments?
Yeah, I think it's a nice case that interests the trainees. That's and more of practical based. So must congratulate two teams for the presentation.
Thank you.
Thank you. Thank you.
Thank you.
Yeah.
Thank you, sir.
Yeah. Thank you.
Yeah.
Nirmala madam, final comments and then.
Yeah, well presented, and this type of cases with the picture, with the differential diagnosis, it helps the postgraduates to have the differential diagnosis, and also whenever the skin is involved, mentioned about the mucosa and oral cavity. At the same time, we also look at the nails. See,
Yes,
that
ma'am.
is also important point that to be noted down. Okay.
Complete.
And then most of these cases recover, but the only thing during the acute phase is dehydration, electrolyte imbalance, sepsis. These three need to be looked into and managed very well. Okay, because there will be a lot of raw area where insensitive, evaporative losses will be very high. And even IV line becomes very difficult because wherever you apply pressure, there will be a skin peel will happen. So it is that is very important, and isolation is one thing so that the infection does not spread. But very well presented by both the institutes, both the postgraduates as well as the fellow, Dr. Sneha and Dr. Rafi, and well moderated by their guides. I think well presented, and I think from all the hospitals, such spotters also, we can have a discussion of differential diagnosis and how to manage it. That is more important. It need not be a rare case or see, we day to day what we see also can be presented. This is what I would like to tell everybody that. One thing is, see, this is everybody may know, but what are the differentials and how to manage? What are the type of antibiotics that we need to start, and this becomes very important. Okay, because rational use of antibiotics is what we are discussing about all throughout the last 1 decade. So I think this type of cases will be taken up very well. Yeah, thank you very much.
Yeah, just one suggestion for the students is that try to mask the face of the baby if it is possible while you are presenting, because it's in the forum that we are presenting. Though it's completely academic, we never knew some medical legal issues can
yes
face, and then even the other identification markers also. If you are sharing an X-ray, don't tell the name of the baby.
Yes.
We are all good in the anonymized form. We'll be able to share the knowledge and I think that's one thing. And what Narasimha, what you can do is that 2 weeks prior from the date of the clinical meeting, email to all the hospitals and then all the medical colleges that please share the available cases and other things for the monthly clinical meeting. So that can go as a reminder every weekly after starting from second week or third week, so that we'll have more pull up of and then we can we can keep some of the cases only as a short discussion also, that should be okay. But sharing of the knowledge is more important for us. That's a major idea of these clinical meetings and other monthly clinical meetings. That's what I can say.
Yes.
Thank you very much for everyone to attend.
Yeah.
And I can see
Tejas
the
sir.
numbers have touched almost like 45. Yeah, Vijayanand sir?
Yeah, very quick announcement. Nirmala ma'am and Tejo sir, entire NNF EB, on behalf of you and with your permission, announcement about upcoming CME, which is a hybrid mode by Dr. Amit Gupta and one of his colleagues at Rainbow Children's Hospital. It is NNF program in collaboration with Rainbow. It's going to be hybrid. This is going to be on 3rd of February, that is a Tuesday next week, and preceded by the lunch. There will be 2 talks, and the theme is recent advances. So, and the flyer will share by tonight, actually, tonight by tomorrow. Yeah. So I stop it there, sir.
Thank you. Thank you very much, sir.
So all are invited for the CME.
All are invited. Yes, ma'am.
I would also like to extend an invitation to all to attend National Neocon at New Delhi in
Yes, sir.
December.
Registered are already registered.
So anybody who is not registered may please register. Anybody who is not a member of NNF may please become member of NNF and IAP.
Early
Sure,
bird
sir.
is still on, sir, then?
Yes, for you it will be on.
Thank you.
Okay,
Thank you, everyone. Great discussion.
Thank you.
You can stop sharing, Rafi.
Okay.
Yeah.
Shall we close, madam?
Yes, yes,
Yes,
yes.
yes.
Thank all the
Thank you,
seniors
sir.
for joining in and all the students. Yeah.
Yeah.
Thank you. Bye-bye.
We touched almost 45 plus, madam. That's a
Yes.
good number to start off this year.
Yes, yes.
Let's
Yes,
see
yes.
and then how it will go.
Yes. No, it will improve. No.
Sure. Thank
Yeah.
you.
Okay. All the best. All the best. Bye.
Thank you,
Thank
sir.
you, sir. Thank you. Bye-bye.